So as told, let us continue with Dr. Carrol.
Good morning. Can you hear me?
Yes. Dr. Carrol,
And
thank
you
you
can
very much for jumping in, or apologies for me misreading the program.
No worries. I'm here. I wish I was there. Instead, I'm stuck in rainy Sheffield in the UK.
Okay.
I'm going to share my slides now, so hopefully this will work.
Yeah, we can. All right.
Can you see my slides?
Yes. You can start.
Okay, so Tom Carroll is my name. I'm a consultant neurosurgeon here in Sheffield in the UK, and you can see on the slide where Sheffield is. We do also have a gene therapy program here in nervous system disorders, and you can see me with Professor Moumoun Azouz, who heads up this program here in Sheffield. Just hang on one second. I'm just going to go into presentation mode. But there's a little bit more to my story as to why I'm having a conversation with you, and not just because I'm a neurosurgeon. My first contact with gene therapy was associated with my eldest son, who's now 19. And you can see there in 2006, he had a bone marrow transplant for a cancer genetic disorder called Fanconi's anemia. And along with a number of other parents at the time in the UK, we set up a charitable trust called Fanconi Hope in 2008. And one of the things we did was set up an international working group with our American partners. And from that came a European clinical trial on a gene therapy sort of process. And now there's a product available on the marketplace, about to go into the national healthcare system in the UK for individuals with Fanconi anemia who don't have a matched sibling donor to deal with the bone marrow failure, leukemia aspects of that condition. So that was my first exposure to the whole gene therapy process. And you can see there's a photograph of a whole range of sort of international experts around the table. And you can see me in the top left corner. And the chap next to me in the orange t-shirt is the father of the gene therapy for the bubble babies, immunosuppressive disorders. You may have seen bubble babies in the news. And sort of what you guys are sort of up to embarking on today. That's not the only exposure I have to the issue. I've got two other children. I've got a 17-year-old Katie, and I've got a 12-year-old Jonathan, and both of them have neurodevelopmental disorders. Katie has a condition called Rett syndrome. It's quite a profound disorder. She's nonverbal, poor mobility, and I guess many of the challenges that you guys face with your condition. And I got a lad who's poorly verbal autistic, who's currently waiting results of whole genome sequencing and hopefully a label for his condition. I have been involved in the Rett syndrome community about giving them advice around gene therapy, accessing the central nervous system, and I've also been associated with some of the biotech companies in that area too. So in terms of giving you a little bit of a feel around accessing the central nervous system from a gene therapy perspective, I guess there's sort of 5 ways of getting the stuff in. In an ideal world, we'd do it intravenously. So that's one method that is used in a condition called spinal muscular atrophy. The other means of getting it in are putting directly into the nervous system. We'll mention a couple of those, but the one that I'm going to focus on in my little talk is the green arrow. And essentially that is what we call intercerebroventricular, or getting it into brain fluid cavities in the brain. Equally, there's a method called intrathecal, which is injecting into the spinal fluid at the base of the spine. You can also inject into a small fluid cavity at the base of the brain, at the back of the head, called the cisterna magna. and you can also inject it directly into specific targets in the brain, intraparenchymal. Now, for a condition like Rett syndrome, we want the whole brain exposed, and I guess your condition as well, then it really comes down to putting it into the cavities in the brain, or ICV is the acronym for that. So that's what we're going to focus on. In an ideal world, it'd be great if we could give it intravenously, but unfortunately, as the bar chart shows, you have to give a very large amount of product, which is very expensive. You also risk causing systemic problems like activating the immune system or liver or heart toxicity. So there's a cost and toxicity element to that. And certainly for conditions like Rett syndrome or yours, the current sort of accepted direction of travel would be ICV, putting it into the brain fluid cavities inside the head. So a couple of things about getting stuff inside of the head. I'm a neurosurgeon. Can brain surgery be justified? Well, I mean, we're talking about serious conditions here. I took a photograph of one of your children off the foundation website, and clearly there's a significant disability here. So yeah, I'd be saying neurosurgery can be justified. You get an argument about, oh, it's too high a risk, and I'll try and sort of reassure you on that. But one thing to say about the brain recovers pretty well to some of the insults you talk about that can hit the brain. You may have relatives who've had a stroke and seen them recover. Unlike the spinal cord, if you injure the spinal cord, it's a disaster. So the brain is a much more tolerable structure. And a lot about what we do in neurosurgery clinically is about custom and practice. It's about taking a whole variety of precautions. One of them is avoiding important parts of the brain. We call that avoiding eloquence. And another is using a lot of technology to make sure we're doing things in the right way and in the right place. And I reference that with the phrase neuronavigation. And oops. So in terms of the sort of usual methods in clinical practice, because that's what we want to pursue, we want to do things that are usual and normal in a hospital setting all around the world. There are essentially two techniques. One I made a reference to is putting something into the base of the spine, sticking a needle into a fluid cavity at the base of your spine. There's no important nerve structures there, and it's a bread and butter procedure. And I give some photographs there of being done on a patient on the ward. It's done on a daily basis all around the world for different reasons, but it's not appropriate for your condition, as you'll see in a subsequent slide, because it doesn't get enough gene therapy product into the brain. It is used in another genetic neurological disorder, spinal muscular atrophy, but that's for a problem that only affects the spinal cord. Before I get on to this ICV, or external ventricular drain is another phrase for it, I just want to mention ICM again, putting it into the cisterna magna. The cisterna magna is a little fluid space at the base of the brain with the red arrow. It was something that was done historically. So 100 years ago, they did used to do cisterna magna injections, and you can read about the history through a particular article that I demonstrated there. But we don't do it currently in clinical practice because there's so many important blood vessels and structures in that area that it's quite a hazardous thing to do. But it is being explored, and you will see it if you sort of delve into the literature on gene therapy. So we're really left with this ICV getting into the brain fluid cavities inside the head. So a bit of a graphic here, a bit of a sort of a data slide, but what this slide is showing is if you give stuff into the brain, like ICV, as shown by the green curves, versus giving stuff into the base of the spine, showed by the multicolored curves, not surprisingly, you'll get a lot of brain coverage if you're giving it directly into the brain. But not a lot of coverage in the base of the spine. But who cares about the base of the spine? It's a brain and spinal cord condition we're dealing with. So this is part of the argument about giving it directly into the brain. So just a little bit of anatomy. The brain is bathed in fluid like a baby in the womb. We produce a pint of it a day. We produce about 15 to 20 mils of this per hour. And there are 4 cavities inside the brain. And I show them here in this cartoon. And these 4 cavities are called ventricles. And what we're aiming to do is put a catheter, plastic tube, through a hole in the skull into one of these fluid cavities. And these are CT scans of people's heads that show the fluid cavities in black, the brain is in gray, the white is in skull. And what you're aiming to do is to get a catheter tube into this sort of black area. ICV is the phrase, intracerebroventricular. And you can see on the CT scan on the right, there is a catheter here shown by the white or the radiopaque material in the cavities in the brain. Now, this is a bread and butter procedure. It's done all over the world. There'll be hundreds of these procedures going on simultaneously as we talk in different neurosurgical units around the world. And in particular, it's used for a condition called hydrocephalus, caused by different problems like bleeding or infection or stroke, where the brain fluid passageways are blocked or disrupted. The one thing to say, though, when we carry out this procedure normally in a neurosurgical unit, the brain fluid cavities are blocked up, they're dilated, and they're an easy target to hit. Getting a catheter into normal cavities where they're smaller is a bit of a harder ask. But there are ways that we do it, and we do it. So how risky is the whole thing? I'd be saying 95% chance of going through a procedure like that without any problems, and 95% chance of winning the lottery. But there are 5% chance of problems happening. And of course, there are things that we do as clinicians to try and stop problems happening, and there are things we do to reduce the impact when they do happen. And the 3 major things that we sort of highlight to people when we're doing consents is about infection, or you get antibiotics at the time, a hemorrhage in the brain as you pass the catheter in, or misplacement of the catheter. Now, where we put the catheter, we put it in the front part of the brain, and that part of the brain, the frontal lobe on one side, is a silent part of the brain. You can cut it out, for example, and not cause much harm to an individual. So if you do get a hemorrhage in that area, it's not a disaster, and the blood clot will gradually dissolve, usually over a week or 10 days. But this is the scan here on the top right with a hemorrhage, the blood shown in bright white. This scan here shows a bit of catheter in the wrong place. It's not managed to get into the brain fluid cavities. So how might we get around that, in particular with cavities of a normal size? So there are a whole range of precautionary things that we do. I've mentioned about avoiding eloquence, avoiding important parts of the brain. So for example, in this little cartoon of the brain, I show the part of the brain that controls the motor, the arms and legs of your body. Well, we make sure we do our point of entry, our hole in the skull, in the frontal lobe, right in front of this important bit of brain. You can see that the blood supply of the brain is over the surface of the brain. So when we pass a catheter through the brain, we're putting it in a bit of brain where there are no blood vessels to minimize the chance of a hemorrhage. The drills that we use have a little safety clutch so that when we push them through the skull, they automatically stop when it comes through the other end. And then we have a whole range of technology like robots or computer navigation in the operating theatre to make sure when we place the catheter that it's in the right place. And of course, we cover the procedure with antibiotics, and we can actually use special catheters that are impregnated with antibiotic, again, to reduce the risk of infection. And then there's specific precautions around post-operative care because you're dealing with individuals that may be agitated or don't know what's going on. And this is all sort of bread and butter in a neurosurgical setting. So there is a little bit of detail that you have to work out around the inpatient pathway, and that I'm sure colleagues will be doing if they're planning a gene therapy trial, getting sort of operational pathways sort of pinned down. For example, how do you confirm that the catheter is in the right place before you give $1 million injection? So there's detail around that. Now, I've got a little recipe book there on the left as to how you do such a procedure. But actually, there's a really good YouTube video about 5 minutes long. If you search on brain book and external ventricular drain insertion, there's a London neurosurgeon who takes his audience through a procedure. It's an excellent video and appropriate for anybody in the lay community as well. So one question I get asked, my daughter, gene therapy and Rett syndrome, would I be prepared to have submit my daughter to a trial where the access is through a brain operation? And the answer is, of course. She is so disabled. She cannot access anything really in her life. She's fully dependent on us. She's non-verbal, poorly mobile, in nappies. And as a neurosurgeon, I will be quite comfortable with that. So I finished my presentation. It's a short presentation, a short time slot. Happy to take any questions, but I'm giving a clear message that essentially supportive of the whole idea of an ICV access in a gene therapy trial for a disorder that globally affects brain structures.
Dr. Carrol, thank you very much. Can you tell us just briefly how you're involved with the CTN and B1?
Well, Spella invited me to give a presentation, and Spella had been in contact with a Rett Syndrome Research Trust colleague of mine, who where I had been involved in the Rett Syndrome Research Trust, and it was that connection. And so, yeah, that's why I've given the presentation. Spella did encourage me to come over to do it face-to-face, but the arrangements I had were really a bit short notice in terms of my own family. But I'd be delighted to be involved in your community in the future or to help out in any way I could.
Thank you very much. Dr. Carrol, thank you also for jumping in.